Great. I guess we'll get started. I'd like to welcome everybody to the HER seminar series. I'm filling in for Dr. West, who wasn't able to chair today. So first, I just want to acknowledge Paladin for the ongoing support for the HER seminar series. I'd also like to acknowledge that the University of Alberta is situated on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. So with that, I want to welcome Drs. Silva and Dhanani, who will be speaking with us today about a really important and timely topic, which is burnout, resilience, and compassion fatigue in donation physicians and coordinators. So I think this is going to be a really well-received and as I said, timely talk. Dr. Silva is a research coordinator at the Children's Hospital of Eastern Ontario. She's been actively involved in organ donation and transplantation activities and has coordinated national and international organ and tissue donation projects focusing on quality improvement in organ donation initiatives. She currently leads the investigation of burnout and resilience in organ donor coordinators with the support and collaboration of Canadian Blood Services, as well as a diverse group of organ donation researchers nationally and internationally. Dr. Silva is going to talk to us today about how burnout and compassion fatigue affects organ and tissue donation coordinators' practice, as well as their mental health, and what kinds of interventions and strategies are proposed to manage burnout. Dr. Dhanani will be following that up. He's an associate professor and the chief of the Pediatric ICU at the Children's Hospital of Eastern Ontario in Ottawa. He's worked with Trillium Gift of Life, Ontario's organ and tissue donation agency, as well as the chief medical officer donation and medical lead for research. So he's leads the donation physician network and is a network which gathers a national community of donation-focused physicians to improve deceased organ donor potential. So this is great with very timely for us with the deployment of the SEND initiative here. It'd be great to hear Dr. Dhanani's thoughts on that. It's also the Donation and Physician Network provides a platform for critical care physicians to access valuable resources, education webinars, and research collaboration. So with that introduction, I think if Dr. Silva, if you'd like to start sharing your slides.
In fact, I'm going to start first, if that's okay. We'll flip it around on you, and I'll add one more change curveball to you. Can you see that now?
Yep.
Yeah. Is that Dr. Silva is no longer a research coordinator, but a staff nursing researcher at Brock University. So that's happened over the Christmas break. And we're really excited for that advancement in her career. And I think she's going to present after me, and you're going to see the value of her career so far and where it's going and how we're all going to benefit from the work she's doing now at Brock University. So congratulations. Thanks so much for having the both of us. I remember presenting at the ATI a couple of years back, and what a great experience it was. And I do miss the opportunity to sit in that auditorium and have a conversation. This may hopefully be second best by Zoom, but thanks again for having us. I'll get right into it with a few disclosures for myself. As mentioned, I do have a position with Canadian Donation and Transplantation Research Program, also positions with CBS, no longer with Trillium, except for hospital donation physician, which may be similar to one of your SEND physicians. And that's the only position I get paid for. And then my own disclosure is that I'm a staunch advocate for organ and tissue donation. And so my views are biased. And I really do think that's equal and important part of high quality end of life. But I think what I want to talk to you about is how we develop trust in the system. I think we've all been reassured over years as we've seen organ donation rates increase and i.e. transplant rates, not just overall, but especially specifically for donation after circulatory death. And I think that's been a shared initiative between the number of provinces. We recognize that Canadian Blood Services helps us create a national structure, but it's the individual ODOs in the provinces as its provincial healthcare and the hospitals themselves and the people, meaning you, that promote organ and tissue donation to make this happen. I think I was asked here because of this great news where there was some funding and appreciation for the value of intensivists at the bedside advocating for organ donation here in Alberta. I think this is an excellent extension of what we've started and the SEND acronym, so that not only for donation, but neuroprognostication and specialists in end of life. I think what's been interesting since we started our initial donation physicians in Ontario somewhere around 2010, and that's after we went to Spain and really appreciated what physicians did there at the bedside. We recognized that it wasn't just about donation physicians, though it was a key cog, that there was several elements in a high-performing deceased donation system, and specialists, coordinators, and physicians at the bedside were just one part of that we needed resources and infrastructure, we needed leading practice. We've never really studied this systematically until now, and I'll reference the LEADER program. That's what's happening in Nova Scotia, where the opt-out legislation has been enacted. And for the first time, CDTRP, Canadian Blood Services, Health Canada is looking at the before, during, and after to actually look at which initiatives make sense. My bias is that I think all 6 of these factors are going to come out when we analyze that data, and it's not going to be, for that example, just legislation. And so that's the caveat about donation physicians in general. I think it makes a difference wholeheartedly, but it's just one piece of the cog. You know, I'll give an example of when BC Transplant started having bona fide donation physicians to add to their pool of coordinators at the bedside somewhere around 2012. And since then, donation did increase. But I think you can acknowledge that, was it more policies? Was it changes in practice? Was it public reporting? Or was it the donation physicians themselves that increased? So hard to tease out. Again, that just means we have to implement multiple strategies to do this. When we look at donations, donation physicians, what's helping? Why do rates increase in the environments where they're donation physicians? Is it just somebody there to take a phone call in the middle of the night to help give advice to the intensivists on call? Is it someone to give advice to the coordinators or the administrators at the ODOs? It's probably more than that. We had a forum in 2011 that included representation from all the provinces. And we recognized that it wasn't just one thing, that there were many different models of enacting or enabling donation physicians. In Manitoba, they had a model where the donation physicians actually went into the hospital, took over care. This had been used in some states with good success. Other models like Ontario were hands-off and gave advice and left the intensivists as the MRP, gave advice and had education and training roles, performance management. They were paid. In BC, there was a slightly nuanced model. In the UK, one of the biggest models put in place right now, they have almost 250 what they call CLODs, clinicians in organ donation, clinical leads, to help them with their SNODs, which was the specialist nurse in organ donation. I think we did better by using terms like hospital donation physician, HDP. I'm not sure I would have been like to be called a CLOD, but at the end of the day, maybe I am. But we recognize that there were multiple roles that a donation physician could enact. And in every jurisdiction that we've seen a donation physician come in, we've seen success. Now we'll question what success is, but I think what I wanted to point out is this wasn't a no-brainer. I think there were significant ethical issues that we needed to make sure that we address. And as the team in Alberta comes into play, I think this will be an important aspect not to lose. I'll give you kind of a text message example, and these are quotes. You know, hi Sonny, I need can we discuss a case, questions regarding declaration? Of course, I was quick to answer. Is it coming through? Uh-oh, yeah, sure, call me. Hey, thanks for your help. Obviously a busy intensivist in my area. They did declare, you know, we had a discussion. I gave them advice on when to declare, and it had something to do with ancillary testing. They went ahead and declared, but then the conversation with the family didn't go well. Now I said, terrible, can we chat? This physician, who I know pretty well, took it personally. I didn't know it at the time. I had gotten involved with the coordinator in the background as the hospital donation physician, and we worked together to actually then get consent, even though that first conversation didn't go well. So I was pretty happy, thinking I'd done my job. You know, more lives saved and a family might be helped in the grieving process. And about half an hour, I got this text. Happy they made that decision. Pretty unhappy about our last conversation. Of course, I was dumbfounded. Do you want to talk now? He was pretty mad. He didn't even want to discuss it. And I think this was telling. Somehow you managed to make me feel bad about the thing I've been working my ass off to accomplish for the last 24 hours. So it really struck me that at the time, I felt that donation support physicians could only do good, but recognize that intensivists at the bedside have done a good job for a long time. And for us to come in and expect we can always do better, or to get in the way of processes and conversations, we need to be especially careful. So the ethics of that, we did put a subsequent document out to reflect on the areas that might be complex. And this is about managing real and perceived conflicts of interest. That's with end-of-life care versus the advocacy for donation and transplant recipients, to making sure that interests of the dying patients who become organ donors, you know, it's about the end-of-life care rather than the organs recovered, to anticipate ethical tensions, and really to work together to improve the process and quality of deceased donation and end-of-life care together with the intensivists who aren't donation physicians, and really to build trust rather than the goal of increasing organs. And I think that's really an important message. So that leads me to what is success and what are the factors to get to the success? Well, you know, at the end, it's hard to measure that success because there's so many other things going on if we're just saying it's about organs, but that's there too. Here's some anecdotes of Ontario when we first started donation physicians, where one hospital physician implemented mandatory pre-approach huddles for all end-of-life care. So the coordinator and the ICU physician and the care facilitator and the charge nurse all every morning looked at which ICU patients would be best approached. And in fact, in that hospital over a year, their organs transplanted almost tripled. Another example was pretty simple, that they just normalized the criteria for when the organ donation organization should be called. It's pretty simple, and it had been standardized. But in fact, just making sure that the nurses knew about it, the physicians knew about it, actually almost tripled that hospital's donors that year. These are pretty significant. There must be so many other factors than just one person bringing the team together. But I think what we saw is there might be other ways to evaluate. Amy Sarti, an amazing qualitative researcher in Canada, who has a focus on organ donation, took it on to try to look at how we implemented the model in Ontario. And at the end of the day, she found it extremely challenging to tease out what was related to physician leadership at the bedside or in the hospital, but recognized that one thing was important, that it was about connections. So having a nursing lead, a physician lead, and an administrative lead in every hospital was really important. Having committee was really important. And in fact, creating a network was really important. I think in this graph, I might happen to be that yellow dot as the chief medical officers. We had regional medical leads, and then we slowly expanded to have more and more hospital donation physicians. And you can see how the connections continue to grow. And this is after just 1 or 2 years of a model being implemented. Now, what would be interesting is to go back to the social network analysis and look at all intensivists, look at the nurses at the bedside. In fact, Vanessa herself has done social network analysis, not from a physician leadership side, but from an organ donation coordinator side. So interesting how valuable these networks are. And so it leads me to the focus of, or the main point of my part of the talk is about communities of practice. And really, I was really helped when we started thinking about this by Karen Dryden Palmer. She's a nurse specialist at Sick Kids and has done a lot for organ donation in pediatrics as well, but her main focus of interest is communities of practice. She taught me about features such as, organizing it around a shared domain of interest, i.e. organ donation, based on commitment. And I think many of you on the call have that, and developing expertise, that we engage in joint activities, and it's about forging relationships by sharing information and helping each other. Maybe the ATI webinar series does exactly this. And then the members are practitioners, and it's about interaction rather than just listening in. And hopefully our Q&A takes that to fruition. Now in ICU, we've got many different models or examples of this model working. The Canadian Critical Care Trials Group has over 300 members, many research initiatives that many of you are probably involved in, that really is unique to Canada, and a model that's viewed across the world as being a highlight. The CDTRP is another research organization that uses this same model, bringing donation specialists and transplant specialists into the same community, bringing patient, families, and recipients into that, and donors into that mix, and now moving to expanding to ensure sex and gender are priority, and Indigenous and rural and remote populations are part of this community. Really a fascinating growth for CDTRP as a community. And really the impact of this is to foster this community, not to just listen, but to build a national collaboration, to strengthen all the clinical and social supports, especially when groups are small. And I recognize that in Ontario, there's money and there was a system. But we learned that in Saskatchewan, in Nova Scotia, that there were smaller communities in PEI that needed the support of the larger population. And this is where we've really excelled. To be able to provide resources and opportunities to share and learn, but not tell and dictate. And our hope is that we could support national development using these strategies. And so we have two networks now. The Donation Physician Network is a few years old now. And last year, we launched the Donor Coordinator Network through the support of Canadian Blood Services. I'd like to thank them again for the number of slides they put together for me. From starting with 1 or 2 physicians in each province, you can see how we've expanded. I think in Alberta, you can see the 16 physicians that have now been added there, from just 2 regional leads to now the SEND physicians have been added. So we're looking forward to engaging and expanding. Now, really, this is a group of physicians that formally designated. Many of them are paid, and some are more informal. Many of those are trainees gaining experience into the system. And of course, over 180 donor coordinators that work with the ODO. And some of these calls where we combine the physician and coordinator webinars are absolutely fantastic when we look at the interaction and the learning. What do we do and what have we done? We have monthly webinars, and I'll admit that we took some time off for the last 2 years with COVID. I think people's bandwidth was stretched when it comes to the ICU community. Some places organ donation were lapsing, but we took the opportunity to share information about what other ODOs were doing, what our Canadian transplant system was doing with COVID. So it was really helpful. We have a newsletter that goes out mostly monthly as well to those two communities to share information. Really an excellent knowledge translation forum. And what we used to do is bring people together at the Whistler conference, at the Toronto Critical Care Forum conference. Recently, there was a conference in Montreal. This is where we bring people together to have these conversations face to face. This is just an example of KT. I think before the DPN or the DCN newsletter, I'm not sure BC Transplant, where I've been before for these education days, and they're amazing, would have been able to share it across the board to all the people within our community. And we were able to do that for them and share, they were able to share their knowledge with many, many attendees across the country. And I think the Alberta Transplant Institute would fit into that situation to expand the work we're doing and sharing it. So it's not just within your region. We've had a lot of discussions, especially when it comes to emerging topics, fentanyl overdoses, medical assisted dying. Vanessa is going to talk about burnout and coordinators. When it related to COVID, we talked about psychological first aid and grief and loss. We talk a lot about best practices, ECMO and donation, ancillary testing, and we bring in the experts, from Canada. We bring in the experts from across the world. We've had international webinars where the UK and Australia and Spain have joined us. And we make sure that we're having a conversations with each other to make sure we're all on track. And research, we use the platforms and the researchers across the country, and we're able to bring emerging research to the specialists at the bedside. And I think most important, we share interesting cases. This is a forum where it's just physicians and coordinators, and we're able to talk openly about what we saw at the bedside, what was bothering us at the bedside, and many of them deal with ethical issues. And it's really a forum like no other to speak. So where are we going to go from there? Well, we hope it's a shared future. Maybe there's an opportunity to standardize education across the country. Maybe one day we'll have a fellowship in organ donation and transplant to encourage our emerging clinicians to have a focus in organ donation and expertise, just like they do in Spain. We're working with the Canadian Critical Care Society, expanding our network. So when they say join us and contact us, we did. And so we may increase the number of people within our envelope and community. And of course, we're looking outside of Canada. The International Society of Organ Donation Procurement, that's ISODP, is looking for partnerships so that we might expand to the UK, to places in Europe, maybe even the States, to increase our community of practice. And I think that's going to be a very exciting time over the next couple of years. So I want to thank you for walking this journey with me. I think when we look at communities of practice and the DPN and the DCN, this is about building trust. And I really appreciate the opportunity to share what I know so far, and hoping that the experience in Alberta is going to be just as exciting. I'm going to hand it over to Vanessa Professor Vanessa, because I think she has some really exciting research when it look at our community and explaining her work now. So thanks for listening, Vanessa.
Thanks, Sonny. Thank you everyone for this opportunity to speak today and share a bit of our work with burnout and compassion fatigue. Let me just share my screen here a sec. Hope you all can see my slides. And I always like to start by publicly thanking Sonny for all his support throughout my career here in Canada. He knows he's part of my growth and in terms of research and my career path as well. So thank you, Sonny, for that. And we've been working as partners in research for a long time. He's been my mentor since my PhD, and we built this research program together as a team. And as I said, I'm now assistant professor at Brock University, which is quite exciting for me. And the work we're doing with burnout and compassion fatigue and resilience among organ donor coordinators has an incredible team that was put together over the years. We have a core research team that meets regularly, and we also have multiple collaborators that are in and out depending on the projects we're working in. And a bit about the background on burnout and compassion fatigue in organ donor coordinators. Some of you may be aware of the role of organ donor coordinators, so some may not, so I'll just touch base a bit on this. But organ donor coordinators usually have a background in nursing and critical care, and they connect everyone during organ donation cases. So they are in the center of communications during organ donation cases, and they ensure that the process runs smoothly and that everyone is being accounted for with the communications, and also ensuring that we have quality organs for transplantation in the end of the process. But that's not all these nurses do. There's also another side and a bit of my own background. I was an OTDC for quite a while in Brazil, and we do have a similar role as in Canada. And we also have a lot of say in public awareness campaigns and supporting research and everything. So with all this being said, this role is very complex, and sometimes it can become a toll on these professionals, and they can develop burnout, which is the prolonged and excessive exposure to interpersonal and emotional stressors in the workplace, or compassion fatigue, which is the exposure to other suffering. But also moral distress sometimes when they have to do some tasks that they believe is ethically wrong, but some constraints at work prevents them to say no. And that may impact on their decision to continue in the profession, and many of them decide to leave. And those increased turnover rates may impact the ability of organ donation organizations to optimize donation. And we've learned with this work that it may take up to a year for an OTDC to be trained and feel confident to go back into the field and deliver care to the families and donors. So the only article we found on this mentioned that job tenure of OTDCs is around 3 years, which is quite fast. So a while ago, we developed the BRIC research program, which started as an idea from the past director of organ donation at CBS, who had an experience in her previous work as an ODO manager, where her employees were telling her they were dying on the vine. They were so exhausted with all the work and feeling drained. So she proposed to have an intervention from a specific institution, and she saw some benefits, and she brought their idea to Canadian Blood Services, and that's when I got into the picture, and we started this work in 2019, first as a 3-phase study that was planned with the core projects. The phase 1 was a scoping review that we did to identify what was known about burnout and compassion fatigue specifically to this population. And we identified that a lack of research in this area, so we decided to add some additional projects, like a working meeting, which was a very important meeting where we brought together some organization members to discuss this topic. We also evaluated the intervention that I mentioned earlier, which is published already, and we also designed a reflexive narrative paper in collaboration with organ donor coordinators, so they could voice their concerns and their opinions about burnout and compassion fatigue. We're currently on phase 2, and I'll touch base a bit on each phase here of this project and a bit of the results of each of the projects that I mentioned here. So for the first phase, as I mentioned, was a scoping review, and we identified in many papers some aspects of burnout and compassion fatigue that were mentioned by authors, including defining characteristics, demographic predispositions, protective factors, coping strategies, etc. But there wasn't a consistency in the terms used by the authors about burnout and compassion fatigue. And also the prevalence of burnout was found to be positively related to the incidence of compassion fatigue among OTDCs, and mostly because of the nature of the job, working with death day in, day out. That's a lot of emotional exposure to this population. And we definitely found the need for a more in-depth analysis, which just supported the work that we're doing with the BRIC study. For the qualitative initiative that we evaluated, we did a qualitative study, and we interviewed 7 coordinators that attended this specific intervention to understand their views on burnout and compassion fatigue, and also what they thought was positive in the intervention. So they found that the well-being and mental health of coordinators is challenged at work daily, and the stressors that they are exposed on a daily basis and the grief led them to experience signs and symptoms of burnout throughout their career. And in many cases, they mentioned that it was kind of expected of this role that they would feel burned out at some point, which is quite sad to hear. And while they reported various strategies used to sustain their mental health and wellness in the workplace, usually the high demands of their roles jeopardize those, and they clearly needed more support in that sense. In terms of the intervention per se, the intervention was not specifically designed to address burnout and compassion fatigue, but it was designed to improve team cohesiveness and communication skills. They were satisfied in that sense and found positive impacts on cohesiveness and communication skills. And they liked the expertise of facilitators and role playing and etc. But they believe that future workshops should focus on complex conversations and specific training for novice OTDCs, because family interviews for organ donation are very stressful. So that gave us an idea of how this intervention was conducted and in what aspects we could think of implementing in the last portion of our study, of the BRIC study later on. For the reflective narrative paper, we had a series of meetings with coordinators from across Canada, and it was a very interesting set of meetings where we could understand in their view how burnout and compassion fatigue impacts their daily lives, and what strategies they use to support each other, and how they develop coping and protective strategies. But definitely, again, we found the need to further investigate how to better support them in their mental health. So the working meeting was very interesting meeting we had right before the pandemic hit, and we were able for the first time in Canada's history to bring 5 ODOs together to discuss a common issue. So that was a landmark in organ donation research in Canada. And we got very valuable information regarding their needs and expectations to develop the phase 2 of our study. We also were able to engage OTDCs and administrators to develop the next phases, which is very important to us since we take a participatory approach to all of our studies in this area. And we understood that the BRIC study has the potential to have a long-lasting impact on organ donation organizations and OTDCs, mental health wellness. So we're now on phase 2 of the BRIC study, and how that looks like is an explanatory sequential mixed method approach. And that means that we're doing a series of surveys with validated instruments to collect quantitative data and measure the actual numbers of burnout and compassion fatigue, the levels of those in Canadian OTDCs. And then once we analyze that data, we can inform a set of questions for a qualitative interview with coordinators. And then we are going to compare that data and understand what are the actual needs and potential solutions to burnout and compassion fatigue, hopefully. We're ready to start deploying the survey in Ontario, and we recently received a grant that will allow us to expand to other provinces. So we have the survey ready, and it's going to be an online survey that should take about 30 minutes to complete. And after that, and after we analyze all the data, we're going to conduct interviews. So this is Amina, who is now a research coordinator, and myself. We're going to conduct the interview through Zoom. And those interviews will contain open-ended questions with various topics, such as prior training and preparation to become an OTDC, what is their teamwork experience and how that impacts their daily activities. Obviously, touching on burnout, compassion fatigue, moral distress, and resilience. And we added COVID pandemic effects, as this has obviously impacted on the lives of OTDCs that have been deployed to work on clinical settings. And we also want to understand what types of interventions that have been done to try and support their mental health, and what worked and what did not, so we can better develop phase 3 of this study. And phase 3 is gonna come after all of this information is gathered, because we, as I mentioned before, there isn't a lot of evidence in this area, specifically to organ donor coordinators, since this is a very complex nursing role. Not only nursing, because there are other professions that are OTDCs as well, but the great majority are nurses. And then we're going to plan a tailored intervention that is going to target the specific needs of each ODO. So that's the plan. So far, what we accomplished with this work was a series of publications that added to the body of knowledge in this area, which it's quite comforting now that we are starting to understand what are the specific needs of OTDCs. We also brought people together to understand this issue, which is quite important to us, to have their opinions considered in the development of the study, since we're doing this for them, with them, but not, we're not doing it and not considering their expectations. We want their opinions heard. And we also we also submitted a number of grants, and we were successful in some of those, which will allow us to move forward with this study. In terms of next steps, once we identify the work-related issues, in terms of numbers and potential causative factors and solutions, we will be able to regroup with ODOs. So the idea is to have a second working meeting to discuss the results of phase 2 and understand how we can develop the interventions to address the specific needs of the ODOs. And then we're going to implement and measure this intervention somehow. And what can come from the phase 2 can be various things. For example, we can find that there is a structural process that needs to be revisited in the ODOs, and therefore we're going to need more discussions in terms of funding, or if there's a restructure to the program, etc. So we can uncover various things that we don't know, and that's why it's important to have the organ donation organizations as an integral part of this work, so we can better address the issues that come up from the results of this study. And the idea is really to reduce the work-related issues and turnover rates, and improve the quality of life of OTDCs, but also improve the quality of care of families and patients, and also reduce costs to organ donation organizations that will no longer have to hire OTDCs to replace the ones that are leaving due to work-related issues. On another note, so another work that we've been doing, Sonny and I, is to increase awareness of allied research in organ donation and transplantation. And this is an idea that came up from one of our meetings within the Canadian Donation and Transplantation Research Program, where someone mentioned that they haven't seen a lot of nursing research being published, and it wasn't just out there. So I said, well, I'm here, I'm sure there are others, and why don't we create a group to bring these people together, strengthen this research, and share with the community, not only the scientific community, but also people in the frontline care who definitely have the best research questions, but don't have many times the resources to develop those research questions and investigations. So the initial objective was to bridge the contributions of allied health professionals to clinical advancements through research. But after we discussed with CDTRP leadership, we understood that this group objective was to be the entrance door of international collaborations among healthcare professionals and the existing themes within CDTRP and hubs. So we understood that we could provide support to allied health clinicians, and clinicians conducting research with allied health populations to promote this interprofessional collaboration and foster research that is meaningful into clinical practice. So we thought about some benefits that we could provide, like research consultations, access to research experts, and supporting grants application, and etc. And so far, we have 21 members from multiple countries like Brazil, Iran, Spain, and obviously Canada. We have met sometimes already in last year, and we learned some amazing work that people have been doing. So I was the first person to share, just to break the ice. So we shared the REAP program, but we also had Amina sharing her research on quality improvement tools to manage deceased donation processes, which is a scope and review that she's conducting that will potentially inform guideline developments later on. And we also had Professor Silva from Brazil that shared the implementation of the National Biovigilance System, which has a very interesting component, which is a real life data that is shared online publicly on adverse events and errors and etc., so they can analyze and act properly. And we also had Edson presenting his work on return to work and stigma and organ donation, organ and tissue transplantation. He is a member of the Brazilian Association of Transplanted Patients, and in the database, 79% of the patients do not get a job after transplantation, and those who get receive approximately $200 per month, which is not a livable amount, right? So what we're trying to accomplish with this presentation is finding common grounds and finding collaboration. So now we're trying to connect them with people here in Canada to understand how we can better study patient-reported outcome measures and support patients after their transplantation. And also with Professor Bertira, we may have some potential to collaborate and further develop the biovigilance system in Canada as well. So the goals for this group are to support the connections, as I said before, with potential collaborations, but also invite other allied health researchers international to share their research and identify new potential collaborations with our DOT, and identify potential funding opportunities to collaborate international, either visiting countries that are in need of research support in allied health, or bringing people here to learn more about research in Canada. So that's the work I've been doing, and that's in partnership with Sonny, and I appreciate the time. And this is my email address if you guys want to ask any questions offline. Thank you.
Okay, thanks very much to both speakers for two amazing talks and really inspiring work both of you are doing. I want to just start off by expressing the regrets of our donation coordinators who want to be here today, but they're getting so crushed with work, actively burning out, that they're not able to be here. So I've been messaging with them, and they're trying to get freed up to get on, but they haven't been able to. So we could definitely use some of this input here. So I just want to make sure everybody knows you can either raise your hand and I will read out the question, or feel free to type your question in the box. Maybe I can start off just because I have the floor. So Dr. Silva, I was wondering, you know, as a transplant physician, I often kind of wonder in the middle of the night about this exact subject, about kind of how these coordinators are doing it day to day. And I'm wondering, do we know anything about what transplant physicians and surgeons can do to you know, support their coordinator colleagues and to mitigate burnout? And how much of a factor are we in propagating the burnout? I often kind of wonder about these exchanges that happen in the middle of the night, and I try to be friendly, but I often wonder if it's the middle of the night, if you know, some of that burnout isn't arising from those exchanges.
Yeah, sure. That's an excellent question. And I'll also add a piece from my PhD. So what I did a social network analysis from the OTDC's perspective, and some of the challenges that were identified through the networks were that during the allocation phase, it was the most stressful time for them, mostly because they have to deal with expectations from the family, from the ICU, from the OR. They have to manage and coordinate all those timelines. And sometimes it takes longer to get a decision from the transplant teams if they're accepting the organ, passing to another team, or if they are refusing, etc. So that's the piece that we need to start a discussion. How can we improve the allocation process in order to be a most effective one and prevent multiple time reallocation for OR, for example. So usually you have a time, and we know that for organ retrieval, comparing to an accident that has occurred and there's a life-threatening situation, they're gonna give the time to the life-threatening situation if we don't have the team on time, and etc. So that's very challenging to manage, and that's the piece that we need to start thinking on. How can we better support not only coordinators but the whole process per se? And Sonny, if you want to add in, please.
No, it's a wonderful question, and well answered. And I just think it goes to show, Karen, how I think everyone inherently is compassionate for each other and their colleagues, but it comes to a point of not understanding the factors behind the burnout and the fatigue, and really it's not clear how we each can change. And so I think that's the research goal for BRIC. Vanessa and her team is to get the finish line will be to say, these are the strategies that are going to make things better. This is what transplant surgeons should be doing. This is what how allocation should be better. This is how ICU physicians should have role clarity. This is how hard a coordinator should work and when they get to go home, and maybe how we debrief the whole thing. There's so many different angles. I think the good thing about this is that it's not coming from the outside. I think we're going to get this information from the coordinators themselves and have experts in burnout to help us acknowledge these areas and make a change. And we've got buy-in from the ODOs. That's nice.
Yeah, because it really is remarkable sometimes, and they've just got so many demands on their attention, just even on the physicians who are trying to allocate. I think each of them thinks that that organ is the only thing that's going on for that coordinator right now, and so it is a really, I can understand why it's an extremely stressful time. We have a question in the chat right here from Noureddin Burka, and she's saying the HLA staff go through similar burnout and have been asked how we can optimize the deceased donor workout to also accommodate HLA lab techs who work long hours. So I think not necessarily a question, but just a comment and associated burnout and other workers who are involved in this.
Noureddin's put on his camera. Did you have a comment? Do you want to share that? Like it's so valuable.
Can you hear me?
Yeah, totally.
Yeah. Recently, the staff have been asking that we need to review this process. We would have a staff member who worked the whole day from 7 to 3, and then they get called at 7, and they go on for 12 hours in average, one person at a time. And many times they're there waiting for things to happen, for communication to happen. The physician on call haven't even heard about the call many times when we are asked to produce results and not all the pieces are together. So I promise that I'm going to engage the whole group so we could have this dialogue and see how can we optimize this process, because people don't want to do this anymore. And I was actually shocked to hear that the turnaround for transplant coordinators is 3 years. Our people tend to stick longer, but it's difficult and it's tough.
Yeah, I think it's important to have that conversation, right? This is where we're starting. I think actually the community is now open to that. We're hearing, we're much more attuned to mental health issues and being open and honest about it. So for us in the donation transplantation community, I think as a group of compassionate people, I think we're going to be really open to have this conversation. We're going to look forward to it. We're going to help our colleagues. We're going to try to find solutions. And I think this community will be an example for others to say, how do we help each other out? Because this is one of the rare things where it's truly a team approach that crosses so many different groups of people and individuals working for one common goal. That's an amazing thing. And I think we should use that as our strength.
Sure, thanks.
Sonny, and sorry.
No, go ahead.
No, I was just saying that I raised Sonny, and this is going to be the starting point for sure. And we also heard from CHEO coordinators as well, and people who are working on the call centers. So everyone is impacted with the processes during organ donation cases. So that's why we need to think of ways of improving the quality and efficiency of the processes. And we cannot do that alone. And that's why we like this participatory approach where we bring people together and listen from them what is important for us to focus and how can we build you know, a solution together.
Sonny, I was wondering just a bit on the subject of what you discussed. One of the ways that something kind of gets cemented in you know, as we know in any medical field is through training. And you mentioned training for, you know, donation physicians. And I'm thinking that, you know, the certificate in transplantation medicine has just kind of gone live with the Royal College, and I think that's a great way on the post-transplant side to cement, you know, the culture of transplantation and to propagate it for future generations. And I think the idea of training and donation is an amazing one. How close are we to that being a reality, and what would it actually look like for a trainee coming out of an ICU program to do that?
Yeah, so how close are we is a tough question. I'll tell you what we have so far. So we've developed the curricula, you know, and we've developed like online training modules, and Ontario's probably, because it's probably got the most established and largest group of people, has had it for the longest. And we took that as a framework and went national. So we have the material all set up in a digestible form so everyone can access it. Right now, critical care physicians, you know, have through the Royal College, have you know, an exam every year, and there are organ donation questions on that part that are standardized. But as far as extra training, what we're recognizing is every ICU physician tends to do an extra year. It's a 2 to 3 year fellowship. They do an extra year, either a master's in research or, you know, quality and safety, or simulation. And I think having a donation focus as a third year would be excellent. We've trialed it in Ontario, where they worked with Trillium Gift of Life and joined donation experiences from start to finish. And these individuals have come out and now have donation as a big part of their career. So I do think that's the way we'll probably go, as an extra part of training. We've worked with the Royal College, who's very keen on moving forward with this, but I think it's going to take some time, you know, because that's a big deal to make that happen. And Jennifer Hancock out east is an intensivist with a, you know, education specialty, and Canadian Blood Services is really focused on moving that forward. Also, I think that the Canadian Critical Care Society is really interested in promoting something like that. So, you know, I think it'll be smaller changes to create expertise first within the ICU community, and then move that along. So it's not just mentorship and at the bedside training to formalize that. And so I concur with your suggestion that we should move on, get that done.
And I can add to that on the nursing perspective as well. So currently we don't have a certification program in Canada. There are other countries that already have certification programs. So I'm originally from Brazil, and we do have a couple of programs that provide certification for nurses to work in organ donation and transplantation, which is quite good, because sometimes when the OTDCs start working in the field, they have to learn everything from scratch. So if we have the basis of legislation and organ donation processes and transplantation processes, etc., that would facilitate the work of ODOs for sure. It is within my goal to develop something along those lines with Canadian Nurses Association and critical care nurses, but we haven't started a conversation yet. But that's something that definitely crosses my mind as something important for us to develop.
That's wonderful. I'm conscious of the time. We've ended up going a little bit over time. So Murray Wilson had put a really good question in the chat, and hopefully we'll be able to revisit that But thank you to you both for making the time from all the way out east, Dr. Dhanani and Dr. Silva. This was fantastic. And just a note to everybody, Patricia Gongol has put lots of useful links in the chat on the things that were being discussed. So thank you to everybody for attending. And just a note that next week, our seminar will be Dr. Jennifer Chandler. She'll be presenting on legal issues around death and determination in Canada. So just everybody join me for thanking once again, Drs. Dhanani and Silva.
Thank you very much.
Thanks a lot, guys.
Thanks so much. Thanks so much.
Bye.